So thanks very much for the opportunity to present today on behalf of the American Society of Transplant Surgeons. I'll be commenting on proposed revisions to molecular testing for solid organ allograft rejection. Disclosures, CareDx, Eurofins, and Natera have provided financial support to our society over the years. So local coverage determination is the proper process and the appropriate venue for changes to coverage. In March, ASTS requested delay of the revised billing article in favor of a revised LCD process. And we thank you for engaging in this LCD revision process with its attendant opportunity to provide public comment. Proposed LCD revisions were issued in August, and we're appreciative of your admission that a billing article is not the correct mechanism to introduce substantive or significant changes to an LCD. The revised billing article, however, is still in effect and is at odds both with transparency and public process. Our comments today regard the proposed LCD and the existing constraints to optimal patient care imposed by the billing article. So the molecular diagnostic tests in question are an emerging standard of care in solid organ transplantation. Some of the proposed LCD changes are inconsistent with the input provided by subject matter experts at the Clinical Advisory Committee, or CAC, meeting in November 2022. Some of the points made at the CAC meeting, there is significant evidence of the clinical validity of these tests. There is widespread acceptance for the utility in clinical decision-making of these tests. And the CAC supported an expansion rather than limitation of Medicare coverage for these tests. These molecular tests may provide the ability to improve long-term patient and allograft survival, which is a strategic pillar of those of us in the transplant community that care for these patients. The proposed changes to the LCD substantively change coverage, and the proposed coverage changes are not supported by evidence that's abundant in the peer-reviewed literature. The proposed LCD would restrict the surveillance use of these tests to direct replacement of existing surveillance biopsy protocols. Surveillance biopsies used to detect kidney subclinical rejection, but surveillance biopsies are only performed by a minority of centers. Guidelines recommend treating kidney subclinical rejection, recognizing its association with eGFR decline, chronic allograft injury, and graft loss. But the conundrum is that those same guidelines don't advocate for surveillance biopsy, leaving us in something of a quandary. However, there's strong correlation between the covered molecular tests and the diagnosis of kidney subclinical rejection, which gives us a potential valuable solution for our patients. We heard an eloquent presentation about the issues specific to heart transplant recipients. Heart transplant centers have dramatically reduced the frequency of surveillance biopsy by utilizing molecular testing and acknowledge the importance of rejection surveillance using these tests in their guidelines. Molecular testing is not subject to inter-observer variability or the sampling errors that are inherent in particularly cardiac biopsies and may have superior sensitivity and specificity to those biopsies. The proposed LCD conflates the risk-benefit calculations for a non-invasive blood test with an interventional procedure that has significant risks of patient harm and carries with it significant healthcare expenditures. Molecular testing allows surveillance testing when biopsies were not typically performed or planned due to its more favorable risk-benefit ratio. Transplant professionals should retain the ability to determine the frequency of molecular surveillance testing in partnership with the patients under their care based on the immunologic and other risks faced by those particular patients. The proposed LCD would restrict molecular testing based on timing relative to biopsy. Levels of donor-derived cell-free DNA obtained concurrently with biopsies demonstrate that low-grade cellular rejection can be diagnosed and that diagnosis carries prognostic utility. Improvement in donor-derived cell-free DNA after treating rejection is well documented in both kidney and heart transplant patients. Therefore, a donor-derived cell-free DNA level that's obtained at the same time as a biopsy can evaluate the adequacy of response and preclude the need for follow-up biopsies to document successful treatment. Information from concurrently obtained molecular and histologic testing can help clinicians make decisions about immunosuppression management, individualization of that immunosuppression, long-term prognostication, and need for or timing of repeat biopsies. The proposed LCD would prohibit the concomitant use of multiple genetic gene expression profiling and cell-free DNA tests. Definitive diagnosis of disease frequently requires comprehensive multimodal laboratory investigation. Multimodal assessment utilizing donor-derived cell-free DNA and gene expression profiling in solid organ transplant recipients provides complementary information on two distinct biological processes. Allograft injury information is provided by the donor-derived cell-free DNA, whereas recipient immune activation information is provided by gene expression profiling. Paired testing demonstrates better diagnostic performance for the detection of active rejection in both kidney and heart transplant recipients rather than or as opposed to those tests individually. The existing LCD includes language recognizing that, quote, combining both donor-derived cell-free DNA and gene expression profiling may further improve graft rejection determination, end quote, and furthermore states that, quote, these molecular tests have different strengths and weaknesses and can be leveraged for different populations, end quote. We feel that the coverage criteria should allow providers a latitude to determine the appropriate tests for a given patient under their care. In the big picture, it's really all about patients and patient care. Prior to molecular testing for allograft injury and immune activation, we in the transplant community had been performing organ surveillance in much the same way for several decades. The results obtained with legacy surveillance techniques, including urine protein assessment, serum creatinine, urine volume, and tissue biopsy, were and continue to be suboptimal. The failure to meaningfully improve long-term transplant survival, despite massive improvements in short-term patient and allograft survival, remains one of the critical failure points of the transplant endeavor to date, and really is one of the sole areas where we've not seen massive improvement in outcomes over the last several decades. Molecular diagnostic testing may help us unlock significant gains in long-term patient and allograft survival and are already widely used emerging standards of care in the management of our patients. We humbly and respectfully urge you to support the utilization of these innovative tools with demonstrated clinical utility in the complex and vulnerable patient populations that we care for. Thank you so much for letting me present today.